So next we have talk by Seema on DMEK in complicated situations.
Laptop. Where is my folder? Excuse me. Yeah, I got it. So DMEK in challenging situations. Are you seeing the slides, please? Slides on the screen, please. Thank you very much. To answer Dr. Anita's questions in one of my videos. So this is about challenging situations. You will always face challenging situations when you start doing DMEK. So what are the main reasons for it? Poor visibility and poor contrast. Visibility is poor most of our cases because more than Fuchs we have PBK eyes and they have dense stromal edema. Contrast is poor because we have dark irises. So even the bluest of blues also doesn't give you that contrast, you'll see later. Phaco with DMEK or a combined cataract with DMEK kind of situation, you have to do phaco under poor visibility and then start doing your DMEK. Presence of vitreous or fibrin in the anterior chamber to be identified. Vitreous, I would say, still is okay, but if you have fibrin, then it's a worst case scenario. Previously vitrectomized eyes or eyes with ACIOL or SFIOL, these are challenging situations. Large or irregular pupil or iris defects, you need to address those issues before you complete your DMEK. So we'll see a few of these situations now. This is one of my, simple, we saw in Dr. Bhaskar's videos about the endo-illuminator probe that he was using to highlight. So you have a simple endo-illuminator source for DMEK. So this is how you would want your life to be. You know, the kind of contrast that you're seeing, these are all Western eyes. These are all published in literature, they're all Western eyes. You'd like to see your graph so nicely. But what you actually see is this, this, and this. Where is the graft? I can't even see it because the visibility, because of our corneas being so edematous and the iris being so brown. So the problems with visualization in DMEK, the pathological corneas, PBK eyes have poorer visibility than Fuchs eyes, and graft staining fades over time. So the more time you take to open your graft, the more staining is fading all over time. And if the F and S stamp is not visualized well through the hazy cornea, then it would be difficult. So endo-illuminator assisted DMEK has been reported in literature, but what is this endo-illuminator? This is what our VR colleagues use. We have to depend on our VR colleagues. You either have a VR setup or you have a VR spouse. You decide what you want. I have a spouse. 50 lakhs to 1 crore is your investment for the VR setup. You don't really have to go for that. If you want independence, you can have a separate standalone light source. This is also 1.25 lakhs INR. You need a fiber optic probe, which you may borrow from your VR colleague. If they have discarded one, you can always ETO it and use it. It still works. I've been using the same one for the last 2 years with ETOing. It works well. But again, you want something cheaper, very cost effective. You can use an LED torch or your mobile flashlight also. Okay, the point being, you just need that fiber optic light source, which your VR colleague can give you. And then you have the mobile, this is how one of my assistants is sterile, the other assistant is unsterile. She is holding my mobile, flashlight on, and that the VR probe, she's holding it to the back end, the light of the mobile flashlight on the back side of it, and I'm holding the sterile end of the endo-illuminator, the probe, the light probe. We switch off the room lights. She holds it, because this mobile flashlight is very small, you can cover it nicely so that all the illumination is going through the fiber optic probe only. So this is how you can see, this is how without the light probe, and there, if this could be off, that would be great. Ye light off ho sakta hai bhaiya? Ye wala light? Okay. So actually, I am not sure if with this light you can see it, but here is the F mark, which is ulta. Okay, this is an inverted graft, which here I am not able to see at all, but there I am able to see. Here again, this is again comparison. Here I am not able to see at all, but here I have the F. Sorry about this illumination, but I am not saying it will work as well as your VR light, because VR light is very bright. This is the comparison. LED, we did a luxometer also. LED torch gives you 695 lux, mobile light gives you 307 lux. VR or your standalone, the one which I showed you earlier, it's 238 into 100 lux. So 238 into 100 lux, okay, that is your illumination. Obviously that is going to be much better, but this most of the time your mobile light is sufficient, you can use it and works well. So this is a case where I used it in a case of failed PK. Despite removing all the epithelium, the failed graft, we know it's an endothelial failure, so a DMEK is okay for this kind of a case. I've injected the graft inside, but it's gone to one end, like it shot and it went far in the angle, but whether it's in the angle or in the AC, I'm not able to make out at all. So despite trying to tap and center, I could not see the graft, and I started using, this is the mobile light that I'm using, and I'm looking for the graft, but it's nowhere to be seen. Though I'm sure it went in well, I saw it go well into the anterior chamber, but I couldn't. Then I found it, I've edited the video, I found it, tapped it, opened it, and now it's already with air in situ. Despite that cornea being so hazy, I can see the F mark here. So here is the F mark, which I'm seeing well now, despite the cornea being so hazy. So future ideas could be 3D printed attachment device to the mobile so that your dependence on an assistant is reduced. And so coming to the next situation, DMEK with an unwelcome guest. So you can guess this is a case where the iris, the pupil was not small, old cataract PBK eye, and the capsule had fibrosed. So though there was no evident PCR to begin with, I'm trying to open. It's a half fold 40-60, usually opens well easily. But here, whatever I try, I know the graft is in the correct orientation, but when I put the bubble there, the graft got pushed. Something weird is happening here. So I have to remove that bubble and see my pupil became irregular. Meanwhile, my pupil became irregular. So you have that unwelcome guest there. Vitreous has come out. Always before injecting the graft, I'll put air and check if there is anything. There was nothing to begin with. But once I was inside with the graft, vitreous has started coming out. With the graft, you can't take an anterior vitrectomy. You may eat up the graft. So I have to resort to manual vitrectomy in this case. If it doesn't work, I may have to convert the case to a DSEK. But luckily, manual vitrectomy did suffice in this case. With spatula, finally, after a lot of manual vitrectomy, all the vitreous was cleared. Then I was able to center the graft. And again, now the maneuvers to open, flip, if it's origami, again open it, and then tap, tap, and try to open. But here, you know there is vitreous already. You don't want to shallow it too much, lest more vitreous starts coming out. So you have to be very gentle. And once you have reasonable opening of the graft, put a small air bubble under the graft so that you can use the air bubble to now help you. Now I'm keeping the air in the area of the vitreous so that vitreous doesn't come out again, and tap the other side open. Now you leave that air, go back with your cannula and expand the same air. Go merge it with the same air and expand it. Now your graft sits well. So that is about vitreous. Check it and suture your section. This is a case of vitrectomized eye, previously old vitrectomized eye with an anterior chamber IOL. So this case had a very deep anterior chamber with an ACIOL in situ. There was no reason to remove the ACIOL because that was, the PBK happened many, many years after the cataract surgery. So the ACIOL was actually well in position. So I decided we'll do a DMEK with a DSEK backup, and everything goes well. I get a nice double scroll here. But life starts becoming difficult after this. I'm injecting, shallowing the AC, injecting, but as I inject, you see, I want it to go inside. It's gone in a flush, and it's gone to the opposite end. The opposite angle, the graft is now stuck. And there is an AC IOL there. The haptic of the AC IOL is there. So there is an irregularity in the anterior chamber, and my graft is stuck there. How much ever I try to center or tap or do whatever, the graft is not getting released from that end. So the lesson is, how much ever you would not want to touch a DMEK graft, there are situations where you would probably have to touch the graft. I tried to release it with the spatula, tried to open it from the stromal side. Nothing did really work well. So finally, I had to shallow the AC and then take the help of a forceps. This is the situation where you will have to probably hold your graft in DMEK. Trying to unroll with all fluid maneuvers, it's not. Another thing is it's a vitrectomized eye. So in a vitrectomized eye, you usually have shallowing concave caving of the, so here I'm using a forceps, you see that? The graft which is stuck in the angle is now getting released. Finally, it's coming out into the center. There's a jerk with which it comes to the center. Now I'm okay. Now I'm trying to shallow, but it's previously vitrectomized. There is negative pressure, so your cornea is buckling inwards. The cornea is concaving. So that will not usually, the iris lens diaphragm won't come up to shallow. The cornea will go down in a vitrectomized eye. So with that, you will have to tap. You have to be careful. The ACIOL is there. You don't want to graft to lose cells with the ACIOL. So do a little bit of tapping, try to open. And again, like I said earlier, put an air bubble under the graft a little earlier on, and then connect it. You will be able to open the graft. So that is my air bubble going in, a few fish egg forming there, but then finally my graft is open and I'm able to save the day with DMEK. So 6 months follow-up, the patient had, this was the cornea 6 months after the surgery in this ACIOL eye, maintained quite well. So take-home points, avoid compromise in visualization in DMEK. Vitreous needs to be identified and cleared as early as possible. A graft stuck at an angle needs release as priority. No touch may not always work. Vitrectomized eyes have negative pressure. Attempted AC shallowing buckles the cornea inwards rather than moving the iris lens diaphragm forward. A small air injection under the graft relatively early in vitrectomized eyes is helpful. And a stable, well-placed ACIOL is not a contraindication to DMEK. Thank you for your kind attention. Thank you.